Next to the stage and last for the faculty presentations is Dr. Puneet Dhaliwal. Welcome to the stage. Thank you.
Thank you, everybody. Thank you, and a very good afternoon to everyone. My presentation today is primarily a case report. And like you all know, our patients are one of our best teachers. So my case report is on vestibular migraine and benign paroxysmal positional vertigo, which you all call BPPV. It can be a differential challenge both for novice as well as for experienced clinician. So I'm just going to give you a little brief on vestibular migraine prevalence, potentially affecting about 2.7% of the general population, high prevalence in females, and you can find them in young adults to the age group of between 60 and 70 years, and the attacks can last anywhere from a few seconds all the way up to a couple of days. And another thing I want you to know is that there's a 3-time increased likelihood of getting vertigo, that is BPPV, in people who have migraines. Some of the symptoms that are associated with vestibular migraines, that's vertigo, headaches, auditory symptoms. Something that is very unique to this subset of migraines is that people can experience earfulness, ringing in the ear when they're actually experiencing a migraine. Dizziness is also reported at that point of time. And if any one of you has ever experienced dizziness, it's very hard to explain dizziness. The easiest way to say anyone, or especially to a healthcare provider, it's usually we say, yeah, I feel dizzy, but it's hard to explain. So some of the verbiage that's used by this set of patients is that they might feel lightheaded, they might feel that there's swimming sensation in their head, they can feel heavy-headedness in their head, they can feel bloating of their brain as if it's turning into a balloon, feeling of rising and sinking, rocking and swaying as well. They can even feel a pulling sensation. They feel like their brain's getting pulled in one direction. And motion sickness. I love this little emoji here. Always reminds me that how we feel spinny and motion sick. That's exactly how our patients are feeling at that point of time. So for those who don't know BPPV, it's the presence of having vertigo with certain positions. Again, the prevalence is higher in females, about 2.2, to males, 1.5 to about 1. And when we are doing a diagnosis for BPPV, there are 2 basic types of it. We either call them cupular lithiasis or canal lithiasis. And they're basically differentiated based on the amount of time patients experience that sense of vertigo. It can happen in any of these 3 semicircular canals, as you can see. It could be in the anterior canal, in the posterior canal, or in the horizontal canal. They usually have a latency, which basically means when you bring the patient into a certain position, slowly the vertigo attack happens, and then it resolves. But that attack, when it happens, usually lasts for either less than 1 minute, which is the most standard way BPPV presents, and it's called the canal lithiasis. When it lasts longer than 1 minute, that is called cupular lithiasis, and that's where people can get a bit confused. Am I seeing a migraine, or am I really seeing a BPPV? They'll have symptoms, again, very similar to that of migraines. They will have a nystagmus, which is a motion that your eyes have, and they will experience vertigo. Vertigo, for those who don't understand the term, basically means that either the environment is spinning or they are spinning themselves, and they will also experience the sense of dizziness. And the interesting thing with BPPV is that about 20% of these patients will recover spontaneously at about 1 month, and it takes about 3 months, and 50% of these patients will feel better. Migraines, on the other hand, can last for the rest of your entire life. So what does the literature actually tell us at this point of time? So there's some literature review, as you can see on the right side of this slide. And when we compare these vestibular and oculomotor signs, which means we're looking at the eye for our patients, the nystagmus, if you see on both sides, you can see that positional nystagmus, such that we bring a patient into a lying down position, you will see a nystagmus. The smooth pursuits, that is the ability of the eye to track a target, that is impaired in people who have migraines. And especially, it's the smooth pursuits that are found to be standard or generalized impairments such that it becomes choppy. They don't have a smooth movement of their eyes. And VNG findings, which are basically colorimetric testing, where you put hot air or cold air into your ear to figure out how the inner ear is doing. So during those testing, we have a camera on the patient. And if any one of you has seen the Oculus, that's exactly how the camera actually looks like. A bit claustrophobic for patients, but they have special sensors in there to test for the motion of the eye. SN stands for spontaneous nystagmus, that naturally that there will be a nystagmus, but again, the biggest finding there is that the positional nystagmus tends to be present in people who have migraines, and very similar in BPPV. So as you can see, it's kind of similar. So I wanted you guys to see what smooth pursuits actually look like. This is not the video from the patient.
Is much more often detected on clinical examination than unidirectional pursuit deficit. Omnidirectional smooth pursuit deficit is a non-localizing but sensitive sign of brain dysfunction. This jerky pursuit movement does not interfere with vision.
So as you can see, instead of having a smooth motion of the eye going left to right, there was a little bit of choppiness, and that's what you will tend to see in people who have vestibular migraines. As you can see, the eye moves upwards, and it's slow. That's what you will tend to see in people who have migraines. It's not a fast speed, so the velocity of the eye movement usually tends to be slower. And this is a typical BPPV nystagmus. As you can see how fast it is. It goes upwards, it rotates. So there are always two components that you will see in the eye motion. That's a vertical component and a torsional component that you tend to see in people who have BPPV of the posterior canal. I think the challenge for me, I've been doing this for almost 15 years. The thought was still like, what am I really tend to see in my patients? Is it central, or am I seeing a peripheral vertigo, which means am I seeing migraneous vertigo attack, or am I seeing an attack that's coming from the ear? It becomes very important as a clinician, because if it's migraine, your treatment interventions change. If it's BPPV, it's very quickly resolvable within a week's time. So this is an introduction to the case. It was a 77-year-old female. You know, her primary complaints, they kind of started about a week ago before her presentation to me. And she had an increase in dizziness, imbalance. She had heaviness of the head. She had vertigo with lying down and getting up from the bed. She also had nausea. She had upset stomach for the last 3 or 4 months. This patient has osteoporosis, and she was given reclassed infusion, and reclassed when has some side effects, and nausea and dizziness is one of them. But they do tend to resolve within 2 to 3 weeks max. But it was 3 or 4 months that she was getting that. And her MD disagreed that this side effect was coming from the medications. She didn't have any headaches at the time of evaluation, but she did have some sensitivity to light. And per MD, they thought it was BPPV, and she should go and seek physical therapy intervention for treatment of the same. She has a very complex primary medical history, as you can see. You know, she has ocular migraine. She had a history of thymoma. She has osteoporosis. She had GERD. She always had oral fullness that would come and go, and she was a worrier. And I want to highlight that because in migraines, that becomes a very important thing, because if you are stressed, it can trigger migraines for people. She had a previous history of BPPV. I actually initially saw her in 2017 first, and she was coming into the clinic a couple of times, and she was fully resolved. So this time around, we got the ENT testing done. Everything was normal. For those of you who don't know Fukuda step testing, you ask the patient to stand in position, have their eyes closed, and march in place. It's not a very sensitive test for figuring out which ear is a problem. It tells you, ears kind of tell you where you are in space. They had other exams completed for her, given that she had nausea going on and dizziness going on after that reclassed infusion, but her blood work, stool test, everything was normal. For physical therapy exam, she did test positive for BPPV on evaluation. She had a left-sided test positive. We saw that really fast nystagmus on arrival. But at 1 week, all I could see was this upbeating nystagmus that you saw in the video. And at 2 weeks, again, that upbeating nystagmus, no vertigo, but she continued to have nausea. So what were the results? At 1 week, I treated her at 2 separate visits in that week's time with specific maneuver that we use for BPPV. It's called Epley's. I'm sure some of you may have heard of that. But even at that point, her dizziness, nausea, she had mild imbalance, and some light sensitivity continued to stay at that 1 week point of time. At 2 weeks, there was no more spinning, but she continued to have that nausea, dizziness, and that positional testing had switched to upbeating. And given her signs and symptoms, I started thinking that she's probably going through a migraine at this point of time. Why was it not resolving? I wasn't sure. And she definitely had BPPV. So my treatment intervention now included lifestyle changes, and she had not seen a neurologist in almost 6 years, so we decided that she is referred to the neurologist and let them decide what they would like to do further with her. At 6-week mark, I gave her a call to figure out what was going on. She said her nausea had also started to improve with lifestyle changes. She loved dark chocolate every night, so she hated to forgo of that, but she tried it and she actually felt better. So for those of you who are unaware, migraines, there are certain lifestyle triggers, and cheese and chocolate and wine, they tend to be some standard triggers, and they are usually told by all of us who are sitting here, who will be going into the clinic, to our patients to keep an eye on them, because they can be one of the triggers for migraines. So I think the key discussion and the clinical significance and conclusion for this case is that, thinking about migraines and thinking about headaches is not what we really want to think about. There are some subsets of migraines where you can have vertigo attacks. They are called vestibular migraines, and their presentation can be very similar to that of BPPV given during our signs and symptomatology. Second, you want to think about that when patients are coming into you, you might start taking care of someone's BPPV, but don't forget the fact that, they have an underlying problem, that of migraine. That was my mistake. I won't call it my mistake, but more of I lowered my guard for that migraine and never thought that nausea would be a part of that migraine itself. And, really keep it in mind that both of these entities can coexist. And when you're not sure, refer your patients out for the neurologist to help them out. And that's it from my end, and here are my references. Thank you.
Okay, thank you, Dr. Dhaliwal. And that concludes the morning portion of SOHP Research Day.